always does that. So with that in mind, I'm going to go ahead and ask everyone to mute. After each talk, we will have some time to ask questions. Any questions we don't get answered, we'll go ahead and get those answered for you in the following week and get those back out to you. With that in mind, Olamide, I'm going to let you go ahead and share your screen and we'll go ahead and get started.
All right, awesome. Let me present my screen. Great. Can you guys see it? Give me a thumbs up. Perfect. Okay. Hello, everyone. Like Julia just said, my name is Olamide Sonuga. I am a fourth-year medical student and dermatology research fellow at the University of California, Irvine, with Dr. Kristen Kelly. And I'm very excited to speak to you all today about new approaches for evaluating and treating port wine birthmarks. This is going to be very familiar to the presentation that was given last year, just with some few updates. And so I know that everyone here is at a different level of knowledge when it comes to port wine birthmarks. So just starting from the very top, I want to introduce the layers of the skin. There are 3 layers of the skin, the very top layer being the epidermis, which has a lot of our cells and melanocyte cells or keratinocyte cells. We have a very bottom layer, which is our hypodermis, which has a lot of our fatty tissue here. And then the most important layer for this talk is this dermal layer, the middle layer called the dermis. And this is where we'll see a lot of our blood vessels in the skin. And this is a difference that we see with patients with port wine birthmarks because the blood vessels in this layer grow abnormally. So they can be dilated, they can be tangled, and there's a number of different genetic mutations that cause this to happen. But the most common one that we are familiar with is the GNAQ mutation. And additionally, we also know that 10% of port wine birthmarks are associated with Sturge-Weber syndrome. One thing to note about port wine birthmarks is they are not contagious and they're not deadly, but some of the symptoms that people experience, whether it's the thickening of the skin or the color changes or the lip involvement, can be very uncomfortable to live with. So a lot of the treatments that we have now are mainly used to alleviate some of these symptoms. So we're going to briefly talk about what some of these treatments are. The first treatment I want to talk about is the pulse dye laser. It's actually the first line treatment. And what this laser does is a light comes out and it interacts with the blood vessels in this middle layer of the skin and reduces the average number and size of blood vessels while keeping the surrounding skin intact. Earlier treatment is thought to be better for improving the symptoms. And even though pulse dye laser is our first line treatment, there are other types of lasers that can be used. So what are these other types of lasers? I will just briefly go over them. Dr. Kelly will go more in depth into these treatments, but just to give you guys a general overview, there's 4 main ones that we use for port wine birthmarks. And the main thing that you should really know about them is that the biggest difference is the wavelength. So smaller numbers like 532 are considered shorter wavelengths, while bigger numbers like 1064 are considered longer wavelengths. And these 2 lasers here, 532 and the pulse dye laser, are really great at targeting more superficial superficial blood vessels. And the pulse dye laser is considered the gold standard, like I just noted. And then our other lasers, like the 755 and the 1065, are really great at getting blood vessels that are deeper in the skin. And so we normally use these lasers to treat port wine birthmarks with any nodules and growths because they can reach really deep. But you want to use these lasers with caution because they can lead to some unpleasant scarring. And so on top of talking about the laser treatments that we use for port wine birthmarks, I also want to briefly talk about some of the ways that we can image port wine birthmarks. The most common way that we use here in Dr. Kelly's research group is called dynamic optical coherence tomography. Very mouthful of a word, but this is a non-invasive imaging device. And if I could say it relates to anything, I think it resembles closely to an ultrasound because it has a probe here that we place on the skin, and we're able to see a live 3-dimensional view of the skin. Very similar to what an ultrasound does, but instead of using sound waves in ultrasound, this device uses light waves. And so what are the kinds of things that this OCT can show us? We can see the blood vessels, how deep the blood vessels are in the skin. We can see the amount of blood vessels in a specific area in the skin. We can see how big the blood vessels are, and we can also see how thick the skin is. And even though it's a great device, it does have some limitations. The biggest limitation is that we can only see about 0.5 millimeters deep into the skin. We can actually see much deeper with the OCT device, but if we want to reliably look at them at about 0.5 millimeters deep into the skin. And so now that I've talked to you about the treatments and the ways that we image port wine birthmarks, I want to talk about some of the research studies that we're doing here at UCI, where we look at both the treatments and the imaging. So this first one was actually recently published in July in JAD, and this was done by Dr. Steenari and a bunch of other wonderful people in Dr. Kelly's research group. And we use this non-invasive imaging device, the OCT, to look at the different blood vessel characteristics in people with port wine birthmarks. And the main point was to use this imaging device to look at the number of blood vessels in a specific area and look at how big these blood vessels are in patients with port wine birthmarks. And how they were able to do this is they took about 5 to 25 adjacent spots on the port wine birthmark, and they measured it using this OCT device. And they also had one control area, which would be the unaffected skin without the port wine birthmark. And they were able to compare the density and the diameter at different depths in the skin. And so we were really interested to see how these factors change as you go deeper into the skin. So looking more into the methods, this is an example here of a 70-year-old male who was in the study, and he has a port wine birthmark on the left side of his face. And so we took 11 adjacent spots. These circles represent how big the probe on the OCT device is. And so we took these 11 spots and we did OCT imaging on all of these spots. And we were able to calculate the average of the density and the diameter of all of these spots. And then there was one control spot, which is most likely on the other side of his face, where there is no port wine birthmark, and we were able to compare the density and the diameter at different depths in the skin. This is another example, 12-year-old female, port wine birthmark on the left side of her face. We were able to take 8 adjacent spots next to each other and do OCT imaging, and we're able to get an average number of blood vessels in a specific area, and also we were able to see how big her blood vessels were in this port wine birthmark and compare it to the other side of her face where there was, a control area where there was no port wine birthmark. So what were we able to see in this study? These graphs really represent it very well. So I'll kind of walk you through it a little bit. So we have a graph where we're looking at the number of blood vessels in a specific area. And we have a graph where we're looking at how big these blood vessels were. So if we look at this top graph, the density, we are taking the ratio of comparing the blood vessels in a specific area of the affected skin versus the unaffected skin blood vessels. And we can see that there's at different depths at the skin. So we can see there's 3 colors that are mainly being presented here. We see greens, we see yellows, and we see red. So the green lets us know that the average density in the affected birthmarks is about equal to the blood vessel density in the unaffected birthmark. It's about 1-to-1 ratio, maybe a little less. And in the yellows, we see that the blood vessels in the affected birthmark is a little bit more dense, just a tiny bit more than the control area. And what we're really interested in is this red. This red lets us know that there is a lot of blood vessels in a specific area in the affected birthmark compared to the control. And the density can be about 2 times, 3 times, up to 9 times more dense in the affected blood vessels than in the unaffected blood vessels. And then lastly, we have this black box here. And this black box is supposed to represent the most shallowest regions in the skin, the blood vessels that we're looking at. So this is the area that's most closest to the top of the skin. And so what are we seeing in this? So we see that when we focus on just the shallowest areas of the blood vessels, we're seeing that there's a lot of red, showing us that the blood vessels are very, very dense at the very superficial layers of the skin. And when we go deeper into the dermis, we're seeing all 3 colors. We're seeing greens, yellows, and reds, showing that there are blood vessels that are super dense, and then there are blood vessels that are not as dense in the port wine region of the face. And then when we look at diameter, we don't really see any consistent view here. In the very shallow layers, we can see greens, yellows, and reds, showing that the sizes of these blood vessels vary, whether you're on the very shallowest region or you're very, very deep into the skin. And so when we focus on this density graph here, this is actually very clinically relevant because it shows that we really only need lasers that target these very superficial blood vessels to treat a majority of port wine birthmarks. And we don't really need to use those other 2 lasers that I spoke about that go deeper into the skin to treat a lot of port wine birthmarks. So this was a really interesting study. And this study was actually done again, but this time we really wanted to see how this would change when we look at different types of port wine birthmarks, because not all port wine birthmarks are created equally. We have flat port wine birthmarks, we have flat port wine birthmarks with nodules or growths, we have hypertrophic birthmarks, meaning like the skin is super thick, and then we also have port wine birthmarks where the skin is thick, and we also have nodules in there. And so we seem to get pretty consistent results here. This is a graph of the density. This is a chart of the diameter. And we can see that when we're looking at the flat port wine birthmarks, we can see that the blood vessels are still very, very dense in the more shallow regions. It's a little bit deeper here. But when we look at the hypertrophic nodular port wine birthmarks, where the skin is thick and there's nodules, the blood vessels here are still very thick, and it actually goes a lot deeper into the dermis than the flat port wine birthmarks. But still, when we look at flat port wine birthmarks and even up to the hypertrophic port wine birthmarks, we're still seeing that most of the blood vessels are very dense in the more shallow regions of the skin. So again, it's actually really effective to use the lasers that target the superficial blood vessels, and instead of using the lasers that target the really deep blood vessels when it comes to treating a majority of port wine birthmarks. And then again, we have this diameter here, which we don't really see any consistency here. The diameter, the width of these blood vessels are pretty varied between any level that you're in, but we're really focused on the density here, and that's kind of the most significant part of this study. So like I said, we can use these lasers that treat superficial blood vessels really easily to help treat a majority of port wine birthmarks. So let's talk a little bit more about these superficial lasers. First one being this 532 nanometer laser. So this is the laser that targets the most superficial blood vessels when we treat port wine birthmarks. And when I looked into the literature, I saw the study from 2017, where researchers used the 532 laser to treat port wine birthmarks on the face. And so what they did is that they had 16 patients receive laser treatment once a month for a year. And the results were checked by comparing photos and doing patient questionnaires. And what they were able to see from this study is that half of the patients showed excellent improvement, while others showed good, moderate, or mild improvements. They were also able to use this software that compared both the before pictures and the after pictures. And the software also showed that there was a significant difference on how these patients improved. So I actually pulled out a picture from this study. And so we have this patient here. She has a port wine birthmark on the left side of her face. And she was part of this study where she received treatment with this 532 laser once a month for a whole year. And you can see that the difference is pretty significant, and she did really well in this study. And so the researchers were able to conclude that this 532 laser, which is the laser that treats the most superficial blood vessels, is found to be a safe and effective way to treat facial port wine birthmarks. So this was really very interesting study to read on. And so I've kind of been talking for a little bit of time. And so I just kind of want to reorient myself and reorient you guys to what I've been talking about so far. So we know that we use the pulse dye laser, and that's the gold standard of treatment for port wine birthmarks. It really is really well at targeting the superficial blood vessels. And I also introduced a couple of studies that we've done that shows the different characteristics of the blood vessels in port wine birthmarks. And the thing that we really noticed from this is that the blood vessels are most dense, most compact in the very, very most superficial layers of the dermis. And meaning that we can use lasers that target superficial blood vessels, and they should do pretty well. And then I also just recently spoke about a study where we used a 532 laser that targets very superficial blood vessels, and that also works well. So that kind of brings our own question as to, we have two lasers that work really well at targeting the very superficial blood vessels, but which one works better? And that's the question we're really trying to answer in Dr. Kelly's research group. And this is the study that we're working on now. We spoke about this last year, but now we have more patients. We've actually completed enrollment at this point, but we're in a follow-up period. And so for this study, we compared the two superficial targeting lasers for different vascular conditions. So mainly port wine birthmarks, but we also tested this on different conditions that affect blood vessels. And so for our patients here, we had them receive up to 4 treatments, and they were spaced out about 1 month apart. We also took OCT measurements, we used that non-invasive imaging device, and we measured their blood vessels before treatment and after treatment for all 4 treatment sessions. And then we also gave patients these patient satisfaction scores where they could compare the 2 treatments. So just want to discuss the methods a little bit more. Here's one of the subjects that we have in our study. She has a port wine birthmark on the left side of her face. And in this one specific birthmark, we were able to split it up so that part of it is being treated with the pulse dye laser, which is our first line treatment. And then the other part of her birthmark is being treated with this long pulse laser, which also is really great at targeting superficial blood vessels. So all patients in this study were treated with both lasers. So after immediate treatment with these lasers, we had each subject fill out a patient satisfactory score. This is an example of what these scores, what this survey looks like. So we have these patients compare both lasers. We have them compare the pain. We have them compare the swelling, the redness, the bruising, blistering, discoloration, and overall improvement for both lasers. And so you can see here, this is a patient who has undergone 2 treatments so far, and they were able to compare for treatment 1, and they were able to compare for treatment 2. So like I said, we're still in the follow-up period, so this study isn't fully complete, but I'm excited to show you guys what we've found out so far. So in terms of who's actually in this study, we have a total of 24 patients. Average age is about 48.6 years old. The youngest person in this study is 18, and the oldest person is 79, and gender is pretty skewed. It's mostly females in this study. And in terms of what vascular conditions we're looking at, more than half of these patients have port wine birthmarks, but we're also interested in other conditions like scars and rosacea and just other conditions that affect blood vessels. When we look at the patient satisfactory score, we actually notice that patients seem to prefer the 532 laser a little bit more. They report less pain and discomfort, less redness, and less purpura or bruising, and these differences are pretty significant. I will say that they did notice that there was a little bit more swelling with this long pulse 532 laser, but the difference was not very significant. And when we asked them which laser improved their port wine birthmark visually, we didn't really see any significant difference. It seemed to be pretty equal. So in conclusion, both lasers actually seem to be very effective in treating port wine birthmarks, so pretty much equally, but there seems to be less side effects when we use this 532 laser. And so we're really excited to wrap up the study and be able to present more on what we're doing here. And then lastly, the last project I want to talk to you about is a study that's been going on at UCI by William Van Treit. He's a PhD candidate here at UCI. He's in the Christopher Hughes lab, and they've been partnering with us in dermatology to actually build port wine birthmark models in the lab, which is very interesting. And this is a way for them to learn more about the biology of these birthmarks and to screen some potential medications. So let's talk a little bit more about what he's been doing and what the Christopher Hughes lab has been doing at UCI. So like I said earlier, we are aware that the port wine birthmark is the most common mutation is from the GNAQ mutation, and this causes blood vessels in this dermal middle layer of the skin to grow abnormally. And because of that, the surrounding skin of these blood vessels will appear pink to red to purple to brown. In a few patients, these colors can actually progress through time. And so what they've been doing in the Christopher Hughes lab is actually building blood vessel models. And you can see this is an image. I know it looks kind of like stars, but I'll break it down for you a little bit more. But what you can see here is in this first image, these white little specks on the screen are endothelial cells, which are the building blocks of blood vessels. And so if you focus on the little white specks as the days go on, they start to get longer and longer. They start to connect with each other and form these networks. And by day 8 and 10, they actually start to luminize, meaning that they become hollow in the center and blood vessels able to go through. And it actually looks very similar to what blood vessels in the body will look like. So it's very impressive that they've actually been able to build blood vessels from the very, very first building block to what it would look like in a human body. And they're actually able now to introduce mutations to understand vascular conditions more. And the one that they're very interested in is port wine birthmarks. So what happens to this progress when we introduce the GNAQ mutation? And this is what they were able to see. So these are 4 images of the day 10 of what blood vessels look like in patients with, a sample of the GNAQ mutation. And these go in increasing severity. So this is the least severe form of the GNAQ mutation, and this is the most severe form of the GNAQ mutation. And if you look here in the least severe form, we see that the blood vessel connections are pretty good. It looks pretty normal, like to what you would see in blood vessels. But then here in this spot here, this white mark here, you see some dilation start to occur. And then as we increase severity, dilation gets bigger, and then it gets bigger until you get to the most severe form where you actually lose the connections of the blood vessels and you really just get these large dilations here. And it's thought that people with port wine birthmarks, their blood vessels probably resemble these 2 images here. And so this is pretty significant because now we can reliably grow blood vessels with the port wine GNAQ mutation in the lab. And this can help us understand more about these blood vessels. We can learn more about how dense they are. We can learn more about their survival time. We can learn more about the size. And we can also learn about other complications that we may not actually be aware of. And another thing is that we can actually screen mutations, because now that we can introduce this mutation into the growth of blood vessels, we can now introduce medications and see how it affects this process. And now this can be a new potential medication treatment for port wine birthmarks. There are no FDA-approved medications right now, but this is just the future that we're looking at. And it's all very exciting work. And William Van Trite has been working on this for 5 years, and they partnered with us in dermatology, and actually a few of Dr. Kelly's patients donated their biopsies for us to, advance in this project. So we're really grateful for that as well. So in conclusion, OCT can be used to image the skin, including blood vessels and epidermal thickness of the skin. In patients with port wine birthmarks, the superficial depths had a higher density of blood vessels, meaning that we really just need the lasers that target those superficial blood vessels to treat a majority of port wine birthmarks. We're still collecting data for our study comparing the 2 lasers, but they seem to work effectively well. Both of them do, but there seems to be less side effects when it comes to the 532 laser when we compare it to our gold standard pulse dye laser. And now we're building new port wine birthmark models, and we're able to screen medications that can be used for the future. So some very exciting work to come. And I just want to acknowledge everyone that's been able to help make this presentation happen and these projects happen. These are my references. And thank you so much for your time. I can take any questions, and Dr. Kelly's here to also help answer them as well.
Thank you so much. That was a wonderful talk. Good job. We appreciate it. And please, guys, ask any questions you might have. Go ahead, Lauren. I see you have your hand up.
No, I don't have my hand up. It was clapping.
Oh, sorry. My bad.
Yeah. No, thank you very much. That was very thorough. I appreciate it. Sorry, I had to go get Avery at the bus stop. So she's now home, and now I can listen.
Awesome.
Yay.
Excellent. Any questions?
And it's all work for the future. So, if there's no questions now, we can continue on, and then maybe people have questions as we go on.
Absolutely.
I did want to ask one question. I'm sorry. I kept trying to unmute myself, but my screen kept going crazy on me. When you were showing the study where the lady had her treatments, well, the patient, I'm not sure if it was a lady or not, where it said the pain level, was that during the treatment or after with the healing?
It's both. I would say with the Dr. Olamide, I'm sorry. Do you mind if I should have, yeah, I would say it's both. I will tell you there's a couple reasons why when we've been using that long pulse 532 nanometer laser, we use a little longer pulse duration, which just means the energy is given a little bit more slowly. And for some people that's more comfortable. So I think that's one of the main reasons. That's a little less uncomfortable, but we're still able to get a really good result with that. So that's encouraging. I think this is not everyone, but the majority of people found it a little more comfortable to do with the 532. Most of the people honestly don't have too much pain during healing the way we do it. But there was a little more swelling sometimes with the 532, but less bruising. And so many people like the fact that there was less bruising.
I was asking because my son really doesn't like Fabriel to get the treatments because he has felt what it feels like to have it done. So, and now that she's 9, he's worried that she's going to be in pain and suffer, and he hates to think that. So I am going to share this with him. So hopefully we can get her back having another treatment.
Yeah.
So, thank you.
And we'll talk a little bit about in the next one about other things we can do to help make the treatments more comfortable too. So overall.
Okay, thank you.
Was there another question? Yeah.
All right. I was just curious, now that my daughter's an adult, my son was saying that some people can like get tattoos over their, get a skin color tattoo over their birthmark to cover up the birthmark that way. Has anyone ever done that?
Well, that can be done. I generally recommend against it for a couple reasons. I mean, of course, always it's a personal choice, but oftentimes it doesn't totally match the skin. And then you can imagine sometimes someone gets a little bit tan or something like that, and then it really doesn't match the skin. Skin color tattoos are also very hard to remove if you don't like them because they can turn darker when you try to do it. And also the healing in the port wine birthmark area sometimes can be a little bit different. So, I mean, of course, it's always a personal choice. And I have had patients, who decided in certain areas it's not only scars. I mean, there are a variety of things that people have covered up with tattoos. I just always tell people to be very cautious because it can be hard to remove. And again, sometimes it doesn't match as you would hope it would. And then sometimes once in a while, I've seen one that was not better and perhaps maybe was more noticeable.
Okay, I was just curious because my son suggested that there are flesh colored tattoos, and it's like, I never even thought of that. But
Yeah.
Thank you.
Yeah, actually, I think it's in my talk a little bit about that. So would it be okay if we go on to the next talk? Were there any other burning questions? I'll share my screen in the meantime. I'm always having trouble with this. So let's see. Let's hope I don't mess this up. There we go. I'm going to move it over so we can see it. Sorry about that. And I will hopefully properly share my screen and we'll get going here. Okay. Can you all see that?
We
I
can.
think so.
Mhm.
Okay, good. Well, I'm at UC Irvine, as we mentioned before. Olamide, thanks for getting us started with that great presentation. I'm a dermatologist. I also have an appointment in our Department of Surgery here, but I've been in practice about 28 years, and really one of my areas of most interest is working with patients with vascular malformations like port wine birthmarks, and I do a fair amount of laser surgery. So as a dermatologist, I'm going to talk about mostly the skin component of Sturge-Weber syndrome, and we'll talk about the port wine birthmark treatment, especially with lasers. And again, I'm happy to answer any questions. Well, there we go. Okay, so I know that you guys may know all of this, but I'm just going to kind of do a little introduction just to make sure everyone's on the same page. So Sturge-Weber syndrome, of course, is a condition that can affect a variety of different things, especially there's the port wine birthmark on the skin. There can be eye involvement and brain involvement. And my colleagues will be talking later about the eye involvement and the brain involvement. But of course, not everyone with Sturge-Weber syndrome have all of the above. Early treatments for port wine birthmark, people tried a variety of different things because we didn't have good lasers, we didn't have good treatments. So people tried, for example, cutting them out. That, of course, leaves an extensive scar in the area. And depending if it's a very large area, for example, half the face or more than half the face, that really is not possible. Even for small ones, it tends to cause really significant scarring in the area. And so that is definitely not preferred. People have also used cryosurgery, so like freezing the area. That's basically almost like burning the area, and also causes extensive scarring. So again, not a good choice. And people have also tried radiation. I actually had tattoo on here before, and I took it off because we really don't see that very much anymore. It is a possibility, but again, you have to be very cautious for a variety of reasons. So lasers have been around for treatment of port wine birthmarks since the early 1980s, although of course they've improved over time, and we'll talk a little bit about that. Laser stands for light amplification by the stimulated emission of radiation. And really the important part of this is that it's light. It's just light that we are able to use in a special way so that we can very selectively target the blood vessels in the skin. we can compare it to a light bulb, and the reason, although they're both light, that the laser is an effective treatment tool, whereas light bulbs are not, is that the laser has all one color of light, whereas a light bulb has multiple colors of light. The laser light is all traveling together, so it's all traveling in a coherent or kind of parallel direction, and the laser light is much more intense than a light bulb. But again, we can control all of these things so we can use it in a very safe way to also be a very powerful therapeutic tool. Now, lasers are used in a lot of different aspects of medicine. These are some of the things that's used in dermatology for. Port wine birthmarks, of course, is what we're going to talk about today, blood vessel lesions, but there are different lasers that we use, for example, for brown or pigmented lesions on the skin. We can use them to remove tattoos. We can use it to remove hair. We can use it to rejuvenate skin when it's gotten older or lost in some of its collagen. We sometimes use it for acne and also for vitiligo, where patients have lost some of the pigment in their skin. So there are a lot of different uses. But really, the objective of our laser surgery is to target a colored structure in the skin without damaging the surrounding tissue. So it really is intended to be that magic bullet, which is really the goal of all medicine, to be able to get rid of something that we don't want in the body, and then to make the surrounding area or the surrounding tissue safe. And so again, in this case, we're trying to get rid of some of the extra blood vessels, some of the dilated blood vessels, but not to damage the surrounding skin, including the surface. Now, when we use lasers early on for treatment of port wine birthmarks, we definitely made some improvement. But they also found with the earliest lasers that there was some scarring. And so the question was, why was that and how could we make it better? And so there have definitely been a lot of improvements that make it better. Let's see. Sorry, I don't know why it went backwards. And there was this theory of selective photothermolysis. Rox Anderson still practices in the Boston area, and John Parrish was his mentor. He doesn't practice so much anymore, but he is still there in Boston. And they came up with this paper that was really amazing and showed how if we just set certain settings for the laser, that we can specifically target the blood vessels and again, not damage the surrounding skin. This is kind of like an image of it, and you can see that the laser light comes in and it can just damage those blood vessels, or in the other area, for example, if we just want to damage the pigment, that's not what we want to do in port wine birthmark, it's the blood vessels, but we can just damage those certain areas and not hurt their surrounding skin. This is one of my favorite examples. This is actually an egg that we've opened up so you can see it. And then we did the laser on it. Now notice you can see the blood vessels there, but look at the surrounding yellow area. It's totally fine. But the blood vessels, which we targeted with the laser, after we did the laser, it made little tiny holes in the blood vessels, which made the blood leak out. And then eventually those blood vessels will go away because we've damaged them. But again, the important part is we were able to damage the blood vessels, but the surrounding tissue looks totally fine. And that's what we're trying to do with the laser in the skin. Now, there are 3 important settings that we have in order to do that. We have to choose a certain wavelength, so the right color of light that's going to target the blood vessels. We have to determine how long the laser is going to be on for each pulse. We call it the pulse duration. And then we set the energy. And each laser surgeon does that when they're going to be doing a treatment. And by choosing the right settings, we can again help to make the port wine birthmark go away without damaging the surrounding skin. This is a graph which just kind of shows how light is absorbed by different tissues in the skin. You really don't have to look at it specifically, but it just kind of shows us, again, there are these peaks here where the blood vessel is absorbed more by the light, and you can see our pulse dye laser. We can very nicely use it on one of those peaks, and that's, again, why we can make the blood vessels go away without damaging the surrounding skin. So selective thermolysis really improved our treatment outcome. Again, this was in the late 80s and early 90s that people implemented that, but we still had a lot of challenges, took a lot of treatments. It still does take a lot of treatments, but even more then. Many of our lesions we don't remove completely. That's something we're still working on. We also couldn't treat patients with more melanin or darker skin types because the laser energy would be absorbed by the surface of the skin. And of course, we wanted to be able to treat all patients, and the treatments were very uncomfortable. I know the treatments can be somewhat uncomfortable now, but even more then. But so there was a new invention. And the idea was that if we cool the surface of the skin, because as the laser goes through, as my pointer there, is the laser goes through the surface, it gets absorbed by the pigment or the melanin that's there, and that causes some of the pain. And it has to do that in order to get to the blood vessels. So the idea is if we could cool the surface of the skin, epidermal cooling, and that was invented at UC Irvine, at least the cryogen spray cooling method of that, then we could protect the surface and we could do a safer treatment for all patients, and we could make it more comfortable. And then we could also, because we're protecting the surface, use higher energies, which are more effective. So this cryogen spray cooling was developed. Again, what it does is cools, just very quickly cools down the surface of the skin. It only lasts a few milliseconds, so not even a second. It cools it down so that the laser light can safely pass through the surface of the skin, get down to the blood vessels, and have their effect on the blood vessels and not affect the surface. And this is an example. It's cryogen spray cooling. It's tetrafluoroethane, actually the first one they actually got at Pep Boys, just down the road from us. And it is still used today, this cryogen spray cooling. There are other methods of cooling the skin. So there are other lasers that also cool the skin. You can use what we call contact cooling, which is a chilled plate. It sometimes has that cryogen, or sometimes it has water flowing through it that can keep the skin cold. And there's also air cooling. It's kind of like a hair dryer, but it's cold air. And that can also be used to cool the skin. So most of the time when people are using, and really all of the time they should, when they're treating blood vessels, they're using one of these methods. Cryogen spray cooling, the first one I mentioned, is one of the most common, but certainly there are other methods that can be used. So this epidermal cooling really helped us to use higher and more effective energy. It also helped us to be able to treat all patients, and it decreased treatment discomfort. So it was another advance that really helped our laser treatments. So now that we know a little bit about, what lasers are, how the developments that have helped to make lasers safe, let's talk a little bit more specifically about the laser treatment. So when a patient comes to me, I want to prepare them. I want to tell them about what's going to be happening during the laser treatment. I do ask everyone, and any of my patients will tell you, I bring this up a lot, trying to do sun protection in the area, because both before and after the treatments, it's helpful, because before the treatments, when we have less pigment, it does help us to get a better effect. And then after the treatment, it helps us to minimize discoloration that can sometimes happen in the skin after a treatment. It's good, of course, for someone who has Sturge-Weber syndrome to make sure you're taking care of all the aspects of it. So I ask about, are they getting their annual eye exams or more frequent eye exams if they need it? And then we also get people set up with neurology if they need it and it is appropriate for them. So we want to make sure that we get them all aspects of their care. Now, we talked a little bit about it earlier, that the treatments can be uncomfortable. And so we want to do everything possible to try to make them a little bit better. And I'd be happy to talk about this more in the questions if people do have questions about it. Of course, we can do no anesthesia. And many of our patients do choose to do that, because we try to do other things when we're doing the treatment to make it more comfortable. There are topical anesthetics that can be used. You have to be careful in using not too much of them, but really face areas we can do. There was some concern for a long time that the topical anesthetics would make the treatment less effective, but there have been quite a few good studies that show that does not tend to be the case. You can inject anesthesia into the area. When we do it, we want to make sure, sometimes they use epinephrine, which shrinks the blood vessels, and then we don't get a very good treatment because the target is not as good, but we can inject into the area, and some patients choose to do that. Some patients get a pain medicine in their arm. That would be something like Demerol, which could be like a narcotic or something like that. Most people don't need that, but if some patients are particularly sensitive, they can. Sometimes you can also do an inhaled anesthetic at some places. You can actually breathe it in for a short period of time. And then for patients, sometimes our younger patients, especially toddler age, we will sometimes, and so I'm talking like 3 years, something like that, we will sometimes do general anesthesia, or if there's really an extensive lesion, or some, for example, some patients have, their face as well as maybe both arms and chest and back involved. If we're going to do a very large area, sometimes we'll do general anesthesia. But there are some small risks to that, and we tend to not try to do it in very young children because there is some concern it could affect development. So I talked a little bit about general anesthesia. Again, we try not to do that just because it can be more difficult for some patients, but it is a brief period of anesthesia. Most people don't need it, and there are some small risks in very young patients, but that is an option if someone's really having trouble with the treatments. At our center, we always have an anesthesiologist, of course, who is focused completely on the patient. Then I can focus on the laser treatment. Our treatments are relatively short, so they're usually done within 10 minutes, sometimes even less. And then we can have the patient recover, and most of the time they're going home within 30 minutes. When patients are having treatments, it's very important that we protect their eyes in a good way. If we're going to be treating their eyelids, sometimes we'll put in a little corneal shield. It looks kind of like a contact metal lens that we'll put in there. Or if we're not treating the eyelids, but just on the face, we can use these laser-safe eye pads or also the meta goggles that we have below. I usually put some little gauze by them so that they're not uncomfortable when you're putting on. But it is really important when you're treating on the face that you have the right eye protection to protect your eyes during the treatment. These are our lasers. There are multiple different lasers that can be used. Here we have 3 of them, but in our laser rooms, we have multiple different choices. As we talked about today, we can use our 532, we can use our 595. There are some deeper wavelengths like 755 that sometimes we use. If there's a nodule, I'll sometimes use our 1064, although 1064 is definitely not my favorite wavelength just because it's much more likely to cause some damage. And so I only use it in select areas where there's really deep lesions that we need to get to. Afterwards, for most patients, I'll have them do ice and they can elevate the area a little bit. Sometimes I'll tell people if we treated an eyelid, maybe, sleep with an extra pillow or something like that. That just helps to minimize the swelling. Sometimes mild analgesic, like, acetaminophen, Tylenol is a brand name of that, right? So sometimes we'll use that. But I find that many patients, by doing things carefully and hopefully icing right away, that we can minimize their need for pain medicine later. And I always give a little sterile Vaseline packet to patients, so if they do get a little scab or blister, they can use it. But my goal really is to not have patients blister. And then I already talked about the sun protection and why I think that's important. We do repeat treatments. It depends. Sometimes we have people flying in, so it might be a little longer in between treatments, but especially in young children, we try to do them at least every 4 weeks. But there is some new evidence that, even doing treatments on a weekly basis, especially in very young children, might be beneficial, so that even by 6 months, they may have some of the port wine birthmark, or maybe even the majority of it that's very light and hard to see. So how can port wine birthmarks change over time? This was a study by Roy Geronimus a little over almost 15 years ago now, just showing that, and this does not happen for everyone, but there are patients who can progress over time. This was a patient of his that started as kind of a flatter pink to red lesion, over time got darker. But of course, as many of you know already on this is not the case for everyone, but there are some patients it can progress on. And one of the reasons we do try to treat early if patients do want to have treatment. Some patients can have the area that gets a little thicker on the side of the port wine birthmark, probably because the skin is getting a little more blood flow to that area. That, again, doesn't happen to everyone, but that's why it's important. Sometimes we'll involve other physicians. For example, if there is a lot of lip enlargement, this is mild, but for some people, they have more involvement, and we can work with our ENT surgeons if we have to change that. It's also important to make sure that the dentist is seeing the patients, just so they can take care of any dental issues that might arise. What age can we start treatment? Pulse dye laser is safe in any age. So I've had patients as young as a few days old. I've had patients who are almost 100, not quite 100. He was in his late 90s, but honestly, he had helped a number of children get treatment. He'd never gotten treatment himself. And in his early 90s, he's like, do you think that I could have treatment? I'm like, absolutely. So we had him come in, and he had a number of treatments and was really able to lighten up his port wine birthmark. We do think that when we start treatments early, we get a little better result. There are a variety of reasons for that. Infants have some extra blood cells that sometimes help us to get a better result. They probably have less tangled blood vessels that may also help, and they also have a little bit less pigment, and their skin is a little thinner. So there are a variety of things that we think helps. Can laser be combined with medicine? A lot of people ask that. Olamide touched on this a little bit. There are no FDA-approved medications for port wine birthmarks. People have tried a variety of things. Sorry, I shouldn't have moved that forward. People have tried a variety of things, but there really is nothing that's approved now. And that's why we are doing the studies like Olamide showed about trying to screen for new medications. And I really do think, now that we know more about the pathway and things like that, that there will be medications in the future, However, when I say the future, I mean, that's probably 10 years in the future or more, something like that. But people like our group, but then many others across the country and across the world are working on that. One thing that we have shown is that, with there are different imaging, Olamide showed optical coherence tomography, but this is laser speckle imaging, where we showed that, if you treat immediately after, you can see kind of where red is a lot of blood flow to area, blue is where we decrease the flow. So the laser treatment does decrease the flow very dramatically. So you had almost no flow in the area, enough to keep the skin alive, but very limited extra flow. But 1 week later, they actually saw increased flow in the area. So we do know that a lot of the blood vessels come back, and that's why we may need to use medications to kind of minimize that. And that would help people get progress a lot faster. There was this amazing work by Ann Comey and Jonathan Pebsner and the whole group here, and which showed that the GNAQ mutation is involved in port wine birthmarks, the majority of them, and certainly in Sturge-Weber syndrome. And again, as we get more information about this and target the pathways that are involved in, hopefully we'll have new medications. These are some of the pathways there. It's really involved, and honestly, something that it's difficult for me to kind of go through all the pathways, but like I say, there are people working on it. We're excited to work on it. And I think very soon we will have some medicines that we might be able to test further. These are some of the ones that have been used in the past. Propranolol and timolol are used for infantile hemangiomas, a different kind of birthmark, but they do not work for port wine birthmarks. We did some studies on imiquimod, which is a medicine that's sometimes used for warts. It did help a little bit, but wasn't dramatic. And there was also some excitement for a while about rapamycin or sirolimus, but also turned out to not work in the majority of patients. So that's why we need to find new medications. And as you can see, research is still ongoing. Now, there are other diseases where there are medications that work, which shows us that this really is likely to happen. This is one example of patients who have a different mutation that does cause birthmarks on the skin, a PIK3CA mutation. And so there is a medicine that's currently being used for these patients and can help them really dramatically. And then there's another thing called hereditary hemorrhagic telangiectasia, where they get dilated blood vessels on the lip and on the fingers. And again, there's medications that people have been using, which in this particular case has fairly minimal side effects and really can help a lot of patients with their telangiectasia. So I do think there will be something similar for Sturge-Weber syndrome in the future. We're working with Lisa Argan and Beth Drolet at the University of Wisconsin in kind of a collaboration to try to really have precision medicine to be able to have our laser treatments, but also to be able to have medications for the future. So, but I think, the future is now from the Sturge-Weber syndrome. And so we really want to be able to have access to the best treatments for patients. And we also want to continue to the research so we can provide even better treatments. And thank you very much for listening. I will stop sharing. And I would be more than happy to answer any questions.
Thank you, Kristen, as always. It looks like Kristen might have a question.
Yes, I actually do. So let me turn. I don't, you don't have to look at me, but so I have this fear about getting my birthmark treated on my eyelid because I'm scared that it's gonna like blind me. So can you tell me what are the circumstances where you're most likely to treat a birthmark on the eyelid?
Well, I treat the birthmark on the island whenever patients are comfortable with me doing that, but we can definitely do it safely. So I always make sure if I'm going to treat the eyelid that I put that little metal shield in. The way I do it is I put a little numbing drop that's specifically made to be used in the eye. So it's a numbing drop that works instantaneously. I put in the drop and it immediately causes numbing. And then I have it looks like a little metal contact lens. And I put a little bit of lubricant in that so it goes nice and easy. And then I can, within 5 seconds, put that just under the eyelid to protect the surface of the skin. Or the surface of the eye, excuse me. And then I make sure it's in the right position, and then we do the treatment. I have done that way at least hundreds of treatment, if not thousands, to be totally honest. And it can be done very safely. But you do have to have the correct eye protection to be able to do it. But we do have correct eye protection that can be used.
Thank you.
Yeah. Any other questions? You absolutely don't have to have questions, but oh yeah, go ahead.
I had one more question. Is there a norm of like how often my daughter did it when she was a baby, had laser surgery, And now as an adult, I mean, how many times in a lifetime do people do series of laser surgeries, or is it just depend on the severity of the port wine stain?
It depends on the person. It is not uncommon that I'll do a series of treatment for someone and then, we'll wait a little time and then they'll come back and do another series. And sometimes we do that a lot of times. I will be honest with you. I have had patients who've had 60, 70, 80 treatments. So for some patients, that is very standard. I also have patients that I just treat every couple months, and that way we are able to maintain the result that they get, and that's a perfectly good option too. So it just kind of depends on the person, what they're comfortable with, what their life allows in terms of the treatments, how frequently do them, and then how we space them out, etc.
And our insurance, well, I mean, they say it's cosmetic, that it's not, covered. Is that normal?
No, for the most part, especially on the face, we're talking, sometimes I do have difficulty off the face. Most of the time, no, but I do once in a while have an insurance that'll give me difficulty with that. For the face, I almost always can get it covered. I'm not saying always, but almost always we can. And if the insurance company says no, I ask to do a peer-to-peer, which is a discussion with another physician who is screening for the insurance company to explain to them why I think it's important.
Okay, I just don't know what to say to the insurance company to get it to be medically, covered.
You should be able to work with your physician who's going to do the treatment, and they should be able to help you with that. And I think even the Sturge-Weber Foundation has some letters that they might be able to do, but I always explain it as, if we're not going to do the treatment, things can progress. There are a variety of things that can happen to the skin, et cetera, and that make it more difficult for the patient. We talked a little bit about that in the talk. And I describe it as, kind of a return to function or prevention from worsening of function. And then that's the way we're most often able to get it covered.
Okay, thank you.
And let us know if you need help, because we can help with that too at the foundation. Lisa Arkin has also told us that she has plenty of letters too. So
yeah. Lauren, do you have one more question? And then I want to get to Dr. Sa.
I do. And my question is regarding some of your younger patients. My daughter has Sturge-Weber syndrome and Birthmark. We went, had a lot of procedures when she was younger. We went every other month. And now that she's in school, a third grader, we only do it during the winter time so that, we can mitigate the missing school. And so right now we're in we have a couple scheduled on the books for under anesthesia, and our doctor does both lasers at the same time to get our desired effect. But my daughter has also expressed wanting to do it without anesthesia again, and we've tried it. She does get nervous, and I think those life science people are just too much sometimes. But as a doctor, because she really, she takes to a doctor's word, like, a lot better than the foofiness of the life science. Is there something that we can, any tricks to get them more calm to do it without anesthesia?
So there are a lot of different things. And so I always try to work with each individual patient, because I don't know that there's one right answer to this. I mean, and so, I think part of it is just gaining a little bit of trust with time. I mean, I always tell people that I'm working with, especially young children who might not feel as in control, that, look, we can always take a break. I can stop, if you tell me, look, I don't want to do this anymore, then we're going to stop, right? I'm not going to force you to do it. Sometimes with little infants, we have to, you know what I mean? But as they're a little bit older, you want to work with them. Sometimes I'll do like a section of it, and then we can put we put a little topical steroid and some cold gel and ice on there. Sometimes that can help if we do it as we're going along. There are other things you can do. Some people will tap the area. Like I say, you could inject a little anesthesia into the area. That is a needle to do the injection for some people, or the topical anesthetic might be an option.
Yeah, we've done the topical.
Got it. And then you can even do medications. Of course, you have to see if that's appropriate for them, discussing it with your physician, but there are medications that can help with that as well. So I think it's just trying to find the right person. I don't use the systemic medications all that often, but for the right person, it can be helpful. So, and I will tell you, I'm excited about it. We're trying to work on some other things, maybe even a game that kids could be able to do while they're doing it, something for the future. But, we're looking at other ways to make it easier for patients.
Yeah. Okay. Okay, thank you.
Thank you. Olamide, would you like to introduce Dr. Sa?
Yes. Thank you for that great presentation, Dr. Kelly. So next up, we have Dr. Donny W. He is a board-certified ophthalmologist who specializes in pediatric ophthalmology. We're very excited to hear his talk today about Sturge-Weber Syndrome in the perspective of an ophthalmologist. So you can start whenever, Dr. Sa. Nice to see you.
Thank you. Can you hear me okay?
Yes.
Yes.
Okay, I'm going to share my slide. This is the part that always throws me off a little bit. I'm going to share screen 1. Can you see my slide or no?
We do. We can see your slide. It's in presenter mode, which is, oh, there you go. Perfect.
Perfect. Okay, thank you. Okay. Thank you very much. Thank you for the invitation, Kristen. Okay. All right. First, I have no financial interest in any of the things that I'll be talking about today. So I'm going to just get right to the point. First, I think one of you asked an excellent question. Like, you're afraid that during these laser treatments, I'm afraid that you may go blind when the eyelid is being treated for these hemangiomas. Well, you don't have to worry. The eye clinic is right next to the dermatology clinic. So if anything bad happens, we'll take care of it. Okay. So,
However, I will add that we make sure that nothing bad happens when we do the treatment.
That's right. And I've actually, I've been doing this for a long time, just like Dr. Kelly, but I've never seen one. So just FYI. So I'm going to talk about why the eyes are involved in these patients with Sturge-Weber and how do we treat these patients and how we follow. So in order for us to truly understand what's going on, we have to understand the anatomy of the eye. So I'm going to just briefly talk about this just for a few minutes. So you can see my arrow, right? So the light hits the light is transmitted and it transverses through the cornea. And then and right behind the cornea, we have this space that we call anterior chamber, and the light gets transmitted through the pupil, and then goes through the lens, and then goes to this big space that we call the vitreous, and hits the retina, and that image gets portrayed on the macula, which is the center portion of the retina, and then it travels to the optic nerve. And then it goes to the brain. Before it goes to the brain, we have the right eye and left eye. And these two eyeballs, we have 12 muscles that align the eyes so that the eyes can move in perfect sync. And then as the image gets transmitted to the brain, it actually spreads out quite a bit. The cortical visual pathway spreads out so that different part of the cortical visual pathway would correspond to different visual fields. And that is why by checking your confrontation visual fields, we can localize the lesion or where the problem may be. Like if you had a stroke, if you have a brain tumors, or if you have a hemangiomas, component of the brain structures, we can actually, by checking the visual field, we can localize and identify the place of the problem. And with the Sturge-Weber, there are 9 ocular features. So number 1 is that they can have dilated episcleral vessels. And I'm going to show you some pictures of pyogenic granuloma, glaucoma, which is a big one, and refractive errors, and strabismus and retinal detachment, amblyopia, and choroidal hemangioma. And then finally, the visual field defect that I just talked about, depending on what part of the brain is impacted. So here, as I've alluded to earlier, the first part of the front part of the eye is the conjunctiva, which is this white area right here. It's a very thin skin that covers the whole eye. And As you can see, with the Sturge-Weber, you could have these capillary hemangiomas, but these hemangiomas can impact the conjunctiva, the actual eyeball. And you can see these dilated vascular malformations in a magnified view. And then also, sometimes that these lesions can actually be pedunculated, and it can involve the eyelid, and we call those a pyogenic granuloma. And then it can also cause high eye pressures. Now, why does that happen? Inside the eyeball, remember I mentioned that there's this place called anterior chamber. This anterior chamber is filled with fluid that's heavily oxygenated. And then the purpose of this fluid is to provide oxygen for the cornea, which is completely avascular. And once the oxygen and nutrients are depleted, then it has to leave the eyeball through a small hole, so we call trabecular meshwork, as you can see here. So you can see these small holes that we call trabecular meshwork, and these trabecular, and this as it transverses, and it gets collected in what we call a Schlemm's canal. So this is represented by this green color. It's like a circular, if you will, like it's almost like a circular lake. And then once the fluid is collected in the Schlemm's canal, then it gets dispersed into what we call the episcleral vessels, right there, episcleral vessels, which is represented by this pink color. So, for example, if you have a vascular malformations where these the episcleral vessels are not functioning in a, for example, normal episcleral venous pressure should be around 10 millimeters of mercury, and eye pressure is somewhere between 10 to 20. So there's an outflow of fluid from inside to outside. But let's say you have episcleral vessels that with the vascular malformations has a pressure that's 20, 25, or even 30. Then the fluid inside the eyeball cannot leave and it's just stuck. And what happens in that situation is that your cornea will start to swell, and your eyeball will continue to enlarge, and then you'll start having spasms, what we call blinking, the blood flow spasms. So these are the triad symptoms: light sensitivity, watering, and blood flow spasms. So if you have a child with these three symptoms, you should assume that patient may have glaucoma. And then gradually over time, the cornea, which requires oxygen to stay clear, cannot remain clear, and then it will become cloudy. So when you have combination of these three symptoms with cloudy cornea, you really should think about glaucoma, especially in patients with the Sturge-Weber, which is a big risk factor. And so that will, because inside the eye cannot leave the eyeball, the pressure will continue to rise and cause increase in intraocular pressure. And what it does is that it will cause two things. It will cause the eyeball to grow, and also it will press on the optic nerve, and it will result in optic nerve damage. So here, normal corneal diameter is about 10 millimeters in pediatric population, and it can grow to 13, 14, 15. So it will become very noticeable. And then you start to see lines forming in the cornea like this that we call hypostria. And then finally, it will enlarge. You will actually see the eyeball growing here on the right side. And then gradually it will become edematous and cloudy. And then the second structure that it damages is the optic nerve. So this is what the normal optic nerve looks like. It looks just like this. It's a circular shaped structure with about 1.2 million ganglion cells egressing to the optic nerve. But with the increase in intraocular pressure, these ganglion cells will start to atrophy. And now you'll see this void of tissue. So now the optic nerves will look very different. As you can see, it will look pale because of the death of the ganglion cells. And this can be identified using a specific device that we call OCT, ocular coherence tomography. And on the right side, you can see devoid of tissue, this red color, as you can see on OCT. And also when you're taking a photograph, and you'll see a abnormal reflex. So normally you should see a red reflex that's symmetrical, but if you see a white reflex on one and a red reflex on the other, that's a no-no. That's a sign that there's something is going on. And get a glaucoma is one of the things that you should be thinking about. And also, another thing that you have to think about is that, as you can see, the colors of the retina looks different. You see how on the right side it's kind of reddish in color, and left eye is like has kind of brownish color. So on the right side, this is as a result of what we call choroidal hemangioma. So hemangioma is impacting the blood vessels that's underneath the retina. So here we have these abnormal blood vessels underneath the retina that's forming and causing a what we call tomato ketchup appearance retinopathy. And this is another picture. It just looks all red. Gradually over time, these retina can detach because of the enlargement of these hemangiomas. And we can detect this on an ultrasound as well. And we can obtain a fluorescein angiography. And over time, it will turn colors. You will see pigmentary changes, and you can see pigmentary modeling over time just from scarring. And then over time, it can gradually lead to hemangiomas, and you can see the retinal detachment. So, and some of these patients can also develop a strabismus. That means misalignment. The eyes can start to drift. So when you start seeing that there's something going on, and the reason why this happens is that this hemangioma can press and distort the anatomy of the eye and cause astigmatism. So astigmatism, what it means is that normally the eyeball should be, the whole eyeball should be very circular. But with the hemangioma, with a mass effect, it can press on the cornea and cause this eyeball that should be circular more elliptical, like this, elongated. And that's what it does. And so when it becomes when it causes a astigmatism, it will result in blurred vision. And when you have blurred vision, that eye will become lazy, and then eye will drift in that order. And and that would cause a significant refractive error. And we can correct that with the glasses. And if you let this go and you don't correct them with the glasses or some form of treatment, what's going to happen is that when the eyes are straight, you will see the same image on the right and left eye in the corresponding points like this. But when the eyes are misaligned, one eye will see a clear image, the other eye will be displaced and it'll be blurred. And so that's what results in strabismus, or misalignment of the eye. And this is what happens here. So how do we check one of the biggest questions is like, how do you check for this? Like, these kids are not very cooperative. And sometimes like they've seen way too many doctors and they're very, very upset. We actually have tools that can help us with this. So we have we have a device that we use to check the eye pressures. And we have we use different light reflex to tell if someone needs glasses or has astigmatisms. And also we have an ultrasound that can measure the length of the eyeball. Is the eyeball actually elongating because of the increase in intraocular pressure? We also have special lenses that can help us to look into the optic nerve. We have cameras that can take pictures of the retina, called the RetCam. A cover test to look for strabismus. So how do we treat these patients? Depending on where the problem is. So for example, if a patient has a refractive error, we correct them with glasses. If patient has a lazy eye or a strabismus, we would treat him with patches or even surgery to straighten it. So if a patient has a glaucoma where the fluid inside the eye is not draining correctly, then we have special devices that will help us to look at the angle of the eye, and then we can perform what we call goniotomy. So we can go in and make an opening so that the water can drain easier. Or this procedure is called trabeculotomy. So this is where we go in and open the tear duct system. The drainage system ab externo in this fashion. So again, let me just mention the 9 ocular features include dilated vessels, the episcleral vessels, which can lead to glaucoma, refractive error, strabismus, retinal detachment, amblyopia or vision impairment, and choroidal hemangiomas. And they can have visual field defect if these lesions, if the vascular malformations is in the brain. And also they can have pyogenic granuloma. And so these patients need to be evaluated on a yearly basis. It's very, very important. They may have normal pressures in 1 year, but a year later, they can have elevated eye pressures or develop any of these other symptoms. So I just want to thank you for this opportunity, and I'll be happy to answer any questions that you may have.
Thank you very much, Dr. Suh. Any questions that, Dr. Suh, you want to, oh, first of all, anyone want to be able to have his contact information, and then maybe Dr. Suh can take the slides down, and then we can see if anyone has any questions. Thank you.
You know what, I have a question actually. If you don't mind, my daughter is on 2 eye drops as it is today, and then she's also on acetazolamide. My doctor happened to be out of the office, out on maternity leave, and we saw a non-glaucoma specialist, and they were very concerned about anemia and the idea of having her on acetazolamide. They weren't a glaucoma specialist, but they were a pediatric ophthalmologist. In your opinion, and please, I'm not holding you to it, but is there a big concern regarding the acetazolamide and anemia?
Yes, I think all medications are poison. They all have side effects. I don't really care what you say. You really have to think about the benefit and the risk ratio. And acetazolamide or Diamox is a sulfa medication. So I want to say, I think the most important thing is that you have to know what is causing the anemia and also how severe is it. But I want to say if it's a mild case of anemia that's not, is not a result of some metabolic disorders, I wouldn't be too concerned. But I think that's something that the doctor should be aware of. Like I said, the two things that the doctor should be aware of is the etiology of the anemia, and second is how severe is it. And then the third, if I may add, the third is the impact of Diamox. Like what kind of impact is it having? And if the doctor is concerned enough, then it should be repeated.
Okay. Right now, she doesn't have anemia. She wants to take her off of it, but we've been controlled with glaucoma with Sturge-Weber for many years. So it was kind of the first time I had heard of it. That was the only reason I was asking the question, because she's tolerating it well. They're outside of that.
Yeah. So Diamox is a very powerful anti-glaucoma medication. And in my opinion, it's probably the most effective medication compared to the topical medication. So I think it will be, if the doctor was concerned enough to start the Diamox, I would recommend that she continue. How old is she?
She's 15.
Oh yeah, I would recommend she should be able to tolerate it, and if she has any significant side effects, she should be able to tell you. So I would recommend that she continue.
Excellent, thank you. Looks like Kristen has a question also.
Yeah, so my question is, you were talking about for pediatric cases where they can't tell you what's going on, that when there was like an increased amount of tears and photophobia, that was a sign of glaucoma. If I already know I have glaucoma, is there any point where I should be worried that I'm having an increased photophobia or tears or anything, or is that just more likely to be just allergies and it's not a glaucoma related thing?
Yeah. Those are symptoms of mostly pediatric population. So I think your problem, I don't think that you're having those clinical symptoms related to the glaucoma, especially if you have a normal pressure. And you're an adult, and you should know what your eye pressure, you should know what your eye pressures are doing. Just FYI, the reason why pediatric population is challenging is that they can't tell you, they can't tell you, my eye pressure is high. And what happens is that when your pressures increase, is that your cornea become edematous, it becomes swollen, and that will cause a blurred vision. And also the light will be refracted in different directions. That's what causes the photophobia, and then watering. And then it's uncomfortable because the eyeball is bulging. And so they will tend to squint a lot. So it's called blepharospasm. So those are the type of symptoms, but those are not typical symptoms in adult patients, no. Good questions. Anything else? Please feel free to ask any question. It doesn't have to be related specifically to Sturge-Weber, just in general as well. This is a great opportunity because you're not gonna you're not gonna get too many ophthalmologists on Friday afternoon to answer questions.
Thank you,
I
Dr.
promise you that.
We appreciate it so much.
I have a quick question. Sorry. I can't see my hand symbol. Oh, I can't see my hand symbol on my phone. So my son, sorry, can you hear me?
Yes.
Yep.
Okay, sorry. I have all these calls coming into my phone, sorry. So my son is 13. He got a shunt when he was about 9 months old. He has glaucoma in his left eye. Severe photophobia, which I think just keeps on increasing. I don't know, they're always just trying to control it. But, and he's on Timolol and Predforte drops. But he has these, which they're trying to control. I guess they call them his ophthalmologist here. He has about 4 ophthalmologists here in Houston, and they're all kind of doing different things. You know, one is they're just trying to make him comfortable because the eye is just always very uncomfortable. But they say, you know, he has like flare-ups, and how they identify that is kind of like he has eczema on his eye. So do you know, I mean, we're just trying to get to the bottom of this a little bit more. And they told us we can use tacrolimus cream in the eye. So we're trying to do that. But I guess we're just looking always for more information. And also, you know, I guess I have questions too about what happens when the eye becomes unhealthy. Like what happens like if the optic nerve gets, I don't know, really sick, or do we have to remove the eye at some point, or these are just all these unknowns that I have. Sorry. Sorry.
Justine, yeah, Justine.
Sorry.
Yeah, Justine, you know, to answer your question adequately, it will take me a while.
Okay.
But I'm just gonna kind of sum it.
I can email you too.
I will just kind of sum it up in a nutshell, because you know what you're asking, I think would be helpful for everyone else. But how old is your child?
He's 13 years old.
Okay, 13 years. Okay.
So he was 9 months when he had a shunt.
Okay.
He's also had, I forget what you call it, band keratopathy, where they remove the calcium buildup.
Okay.
So he's had any, yeah.
Yeah. You really have lots and lots of things. Okay, just a second, sorry. You really have lots and lots of stuff going on, but I'm gonna like just break it down into maybe like just few things to just so that you could have a better handle on it.
Okay.
So we try our very, very best to control the pressure, but unfortunately our success rate is not very, very high in patients with a Sturge-Weber because, as I've alluded to earlier, the mechanism, the pathophysiology of elevated episcleral is a result of as a result of the Sturge-Weber, and we don't have a cure for Sturge-Weber, but only thing we're doing is that we're doing things to lower the pressure with medications, also with the shunt, with the surgical procedures. But so these are mostly temporizing measurement, and if we cannot lower the pressure, what happens is that the eyeball will undergo atrophy. So, and once the eyeball undergo atrophy, you start to form calcific deposits, and we call that a band keratopathy. And then gradually you start to lose vision. So that's, but with a group of 4 doctors, and I actually know the doctors in Houston, and they're all good doctors, and they're trying their best to fight it and trying to maintain and trying to keep the eyes. But sometimes that's not possible. Sometimes it's not possible, but they're trying very, very hard. Number one. Number two, the eczema. So you have, so you can have what we call blepharokeratoconjunctivitis from an autoimmune disease. And so this is a very, very difficult condition that's compounded by Sturge-Weber, and they're not related. So the eczema of the eye or blepharokeratoconjunctivitis can happen in any of the children, and the main treatment modality is steroids. Steroids cause high pressures. So you're trying to lower the pressure, but then you're trying to use steroids to control the eczema. So you're like constantly battling, and that's why it's actually very frustrating. Litmus is a great medication, and I use it sometimes for the eyes. Yes, it's not FDA, if it is not FDA approved to be used in the eye, but we do use it off label. So I best wishes, for your daughter. But
That's my son, but thank you.
Yeah,
And
but son, yeah.
yeah, no, he does have all of that, what you just mentioned. The
Justine, I'm curious, Miss Karen, I'm curious, have you ever tested him for an MTHFR gene mutation?
No.
I'd be really curious for y'all to look into that, because for those of us who have MTHFR gene mutations in our family history, it's not typically something known in Sturge-Weber, but for those of us that have that, we have to be very careful and cognizant of what goes in our body and how we treat it, because if you have that gene mutation, it's very hard for your body to process toxins and amalgams and things like that. So I mean, I don't know,
Okay.
Dr. Sun, Kristen, I'm not trying to practice medicine, but I'd be curious, because why is that body still fighting with it?
Thank you.
I think there was one more question, then I want to get to Dr. Steenari, because she's also very kindly joined us, but I know I'm sorry, there was one more person that I saw did say Deborah, I think I saw that you had a question. Did we lose Deborah? Sorry, maybe she had to go. Okay, well then, Olamide, would you, Deborah, there you are. Did you have a question?
I do, but it's kind of lengthy, so I guess I'll email him.
I'd be happy to can you just make it a little short, and I'd be happy to address it for you.
Sure. My daughter is 21 now. She had the diffuse choroidal hemangioma, detached her retina when she was 10. She went to UC San Francisco, and they did surgery, put oil in there or something to make it go back. Anyway, UC Davis did radiation, and she has no vision in that eye. Is there any possibility in the future for her to get vision in that eye, or is it's because of the lens?
Yeah, thank you, Deborah. I don't want to, I really don't like it when people try to give people false sense of hope. But I'm going to tell you, this is one of the situations that there's lots and lots of research going on, especially with the gene therapy, where we are trying to regenerate the photoreceptors. So unfortunately, with with these retinal detachment, with the choroidal hemangiomas, the treatments are very extensive, and as a matter of fact, sometimes the treatment can be even more toxic and can be the treatment can actually be more toxic than the condition in itself. But there's lots and lots of research that's going on in gene therapy, where we are trying to regenerate some of these cells in the retina. So I would just stay up to date. I'd be happy to keep you up to date on where we are with that. And as a matter of fact, here at UCI, we are one of the leaders in that field of gene therapy of the retina, and I'd be happy to keep you updated on a regular basis. Thank you.
Thank you.
Dr. Suck, what about also, aren't there, I don't know if it's AI technology, but isn't there something now where for people that are blind, they can do an implant of some type that stimulates and they can see again. Is that not something with ours because of the vascularity that would not be possible?
Oh yeah. So it's not AI, it's actually an implant. It's actually a cochlear implant was modified to be implanted
Okay.
in the retina. And
Okay.
it's actually being done here in Southern California. And I think there's still, yeah, it's been worked on extensively, and there's lots of effort. But I don't want to say there's lots of work to be done, but there is there's a group of very smart scientists at the USC that are working really hard to get that advanced. Thank you.
Awesome. Okay.
I was under the impression that the lens was foggy. Her retina was able to be put back with the oil and that stuff, but that they told me it was the lens that was foggy or cloudy.
In terms of for your child, it's actually with the radiation therapy, the lens can be foggy, but the problem is a lot more complicated than that. It's actually the retina. The problem is with the retina.
Okay.
Yeah, with the retinal detachment. Sorry, you guys got a lot of ophthalmology lecture. You guys. I'm going to tell you, 99% of the doctors out there don't know what you guys are talking about. So anyway, thank you.
And it looks like there might be a couple other questions in the chat, if you don't mind looking, Dr. Suh.
I will do that. Thank you.
Thank you so much. Olamide, do you want to introduce Dr. Steenari?
Absolutely. Thank you for that great conversation, Dr. Suh. Next up, we have Dr. Maija Steenari. She is a board-certified pediatric neurologist and epilepsy specialist at CAP over here in Orange County, California. I'm very excited to hear her speak about evaluating and treatment of neurologic disease in Sturge-Weber syndrome.
Perfect. Thank you so much. And thank you for the invitation. Excited to be here. Yeah, I was laughing about that Friday evening comment, but so nice to see so many of you here today. So we have been going from skin to the eyeballs, and then we're going to go even deeper to the brain structures. I'm sure that this was already mentioned previously. What is Sturge-Weber and why is it happening? But why I want to kind of bring this back one more time is it's very important in what time of the fetal development the mutation is happening, because that kind of defines the extension of the brain findings that we have. So depending on if the mutation happens really early on, before the tissues have divided into the left and the right side, your Sturge-Weber findings can be bilateral, so you can have the capillary malformations on the skin on both sides and also on the brain. But if they happen at the later time, after about 5 weeks or so, the changes can be much more focal, both on the skin and on the brain, or in the brain only. We've talked about extensively about the skin manifestations before, so I'll go to the brain. So on the surface of the brain, there's very extensive vascular, fine-tuned vascular structure. And the similar vascular malformations that you can see on the skin can happen on the surface on the brain. And the most common region where it happens, it's kind of in the back here on the occipital or parietal, around the ear areas. But many of our little patients don't read the books, and they can have also changes in their frontal lobes as well. Here, I just attached a picture of a patient with Sturge-Weber, actually pretty extensive changes on one full hemisphere of the brain. We can divide Sturge-Weber into different subdivisions. So some patients can have skin, eyeball, and brain findings. But now we have this Sturge-Weber type 3, and I have few patients like that, and they only have brain involvement. So you can't find a vascular malformation on their skin, and they don't have any ophthalmological changes, but they still have these leptomeningeal angiomatosis in the brain and have seizures and other issues from that. This is imaging MRI of one of the patients that I follow. So what we see on the imaging is on the head CT. So CT looks at your kind of very broad structures, your bones, and we can see big tumors and swelling, but we can see bones and calcium really well. So it's very common that you have calcifications in the same area where you have your vascular malformation. So we can see calcifications on the head CT. On the MRI of the brain that you see here, not only there's a change on the vascular structure on the surface of the brain, but under that vascular structure, the brain tissue is often smaller. We call it atrophy, and that's the tissue that's in trouble, and that's the tissue that causes all the symptoms that we see related to brain and neurology. Some issues that I see in my clinic for my Sturge-Weber patients is headaches. That's very common. I'm an epileptologist, so I see kids with very difficult to control seizures, and many of our patients with Sturge-Weber, we have to do other things than medications to manage their seizures. You can have periods of events that look like strokes, so we call them transient stroke-like events. If the vascular malformation is in the back on the primary visual cortex in the occipital area, you can have visual field abnormalities. So you can have deficits on not only how your eyeball and retina is functioning, but how the brain tissue is what is it doing with the information that the eye is giving it. Also, some degree of developmental delay and intellectual disability is common. Sometimes we have behavioral challenges and psychiatric symptoms as well. When I see a child and we do an MRI of the brain and we discuss, that there's a change on the brain caused by this vascular malformation, and then we discuss about further treatments that I go into a little bit more detail later down the line. Parents always ask, so how are you sure that it's only that one spot that you see on the imaging? Can it be on the other side? Can it grow? So there are a few clues that we can use for that. For example, there are studies showing that if you don't have any skin findings, you always only have one-sided brain involvement, so you never have bilateral changes. But there's high-risk areas on the skin where you see the skin finding that have higher association for either very extensive one-sided brain involvement or very high incidence of bilateral brain involvement as well. It's very common that if you have both sides facial changes, you also have bilateral brain involvement as well. So why does this Sturge-Weber vascular malformation cause the neurological symptoms we see? How I think about it is the vascular layer that's on the surface on the brain, there is the arterial and venous flow is not functioning correctly. So the blood kind of sits there. We call it stasis. And the brain tissue that's under that vascular area gets deficient of oxygen and also nutrition, so glucose and all the energy it requires to function correctly. So slowly over time, there's lack of oxygen or ischemic changes, and we see more and more symptoms. It can also cause cell injury and further gliosis. If that brain tissue that's irritated then has seizures, having a seizure, it's like running a marathon. You require lots of energy, and the vascular structure is not good enough to bring you that oxygen and bring you that glucose you need. You can get further damage. And this is kind of what I already said. So when a seizure happens, there's higher energy need, higher need for oxygen, and the vascular structure is not able to meet that need, and that causes to further ischemia, and that can then further down the line cause more damage in the neurons. Then we see the atrophy, so less of the brain tissue under the vascular malformation, calcifications. Calcium is very irritating to the brain tissue, so that's kind of a vicious cycle on causing more trouble. There's also a thought on not only the vasculature on the surface of the brain that has formed incorrectly. There's also thought of when the neurons go from the deeper structures to the cortex where they're supposed to go, the mutation can cause further abnormalities in the actual cortical development. So not only is the vascular supply abnormal, but then the brain cells that are under it are already having issues and trouble. Seizures. So when you have 2 or more unprovoked seizures, you're diagnosed with epilepsy. So epilepsy is very common with patients with Sturge-Weber. I would say majority, 75–80% of the patients with Sturge-Weber have seizures, especially if you have bilateral involvement. 80–90% of patients can have seizures. Typically, we see seizures at young age, first year of life or so, but they can happen later down the line. So this should be kept in mind. You're not safe if you pass 18 years of age. You can develop seizures in adulthood. So if things change all of a sudden, there's a change on how you function, if there's change on school performance or new events that are quite, we can explain with migraines or so forth, I would look into seizures, but it's most commonly I see little ones, a year or 2 years of age. The classic pattern how our little ones present is focal, what we call clonic seizure. So it's motor rhythmic jerking. And what's quite typical is they tend to be really long. In other epilepsies, most seizures last about 30 seconds to a minute or so, and they stop by themselves, and we don't have to intervene. But Sturge-Weber patients tend to go very long, so they tend to have what we call status epilepticus, and they need intervention with medications. Or some kids, they tend to cluster, so once they have one seizure, then they just have seizure after seizure after seizure after seizure, and we need to intervene. I think there's a connection with the metabolic requirement that I mentioned earlier, when the vascular structure is abnormal and the brain tissue is not able to get what it needs in order to kind of function and organize and stop the seizure, then we're in this vicious cycle, and it's difficult to stop. We know that if there's a child or an adult who has certain amount of brain involvement with Sturge-Weber, and then there's another person exactly the same amount of area, but one is the seizures are under control, and then the other one continues to have seizures, the cognitive outcome is worse on the one who continues to have seizures. So that's why we want to be very, very aggressive with treating the patients. Any patients with little patients with epilepsy, we want to be very aggressive because then brain development is so important in early ages, but definitely with kids with Sturge-Weber, we want to protect that underlying brain tissues that's already in a fragile state and make sure that it doesn't get under this stress of having seizures, and we can make sure that we get to the best developmental outcome that particular person has. There's been some studies showing when we look at the metabolic rate of the brain under when the seizures are happening, and then we get the seizures under control, and we compare, we can actually improve the metabolic function with better seizure control. These stroke-like episodes are very scary. So new deficits, most common events that are visual to us is it's weakness on one side. It can be visual symptoms as well. So if a child complains a periodic changes in the vision and it's not explained by increased like glaucoma or whatnot, it can be a stroke-like episodes from occipital lobe. And sometimes it can be triggered just by minor head injury. And again, we go back to the metabolic requirement and the vascular supply not meeting the demands of the brain. So you have a bump on the brain tissue, and there's a little panic going on in those brain cells, and the vascular supplies is not fully normal. That can cause stroke-like events. It's very common. You know, we call them stroke code strokes nowadays. So you have acute neurological new symptoms, you rush to the ER, and then that triggers a stroke code, and you get lots of imaging and things like that. But it's actually not good for our little ones, especially kids, to get several head CTs down the line. So we want to be cognizant and make sure that we don't get head CTs, once a month if there's a new symptom. So you can also be a kind of with your child if they tend to have a lot of these events where they short period of time they have a weakness or a visual symptom. Yes, it's important to get evaluated, but maybe limiting the head CTs because radiation over time is not good for developing brain. So once we know the diagnosis, we know what it is, then we don't always have to go and do imaging studies. We should look, though, make sure that there are not subtle seizures going on. I've actually had a few of my Sturge-Weber patients. They come to the clinic and parents are telling me, there's just this increased weakness on my child's right side. There was no injury. We don't quite know what's going on. And then we do an EEG and we see continuous what we call subclinical seizure that we treat, and then that weakness can improve. So lots of things to consider and kind of rule out. But we try to do our best to make sure that there's no seizures, stop them, and then treat the brain tissue. I'll go into treatment and prevention a little bit soon. So it's interesting, if you have a patient with Sturge-Weber who have seizures, and then they have headaches, the headaches are actually typically the main concern and main symptom they want to get treated. Patients feel like headaches are causing more trouble with their day-to-day life rather than seizures are. And headaches are often migrainous type. So you can have associated photophobia or light sensitivity, sensitivity to sounds, vomiting, nausea, kind of the classic hallmarks of migraine headaches. There's no association on if you have a bigger area of brain involvement or bigger area of vascular malformation on the face, you have a higher risk for headaches. There's no association with that. So even small changes can cause very debilitating headaches. If you have a family history of migraine headaches, you have a double whammy, and you should definitely be evaluated. I wanted to mention, if you have a young child, a baby who has been diagnosed with Sturge-Weber, and that baby has periods of crying, like irritability, being very uncomfortable, and you can't find a reason why, that can be a precursor of having migraine headaches. So I would definitely look into that. How do we treat headaches, especially with Sturge-Weber? Unfortunately, there's no magic pill. The treatment is the same as with any of our other headache patients. So sleep well, have a regular schedule, drink enough water, and eat regular meals. And then the acute management is the same, ibuprofen or Tylenol, sometimes antiemetics if there's nausea, vomiting. And then prevention, headache prevention is similar to just a typical migraine. So we'll typically try vitamin B2, for example, or magnesium supplementation every day to prevent the headaches from happening. But there's also some other stronger medications that we can use. This is just there was a recent publications on management of headaches with patients with Sturge-Weber syndrome. It's just a nice picture. I apologize, I didn't have more pictures on my presentation, but basically, the triggers are the same. There's the kind of the red flags or warning signs are the same as typical migraines, and the treatment is the same. So I like to use topiramate or Topamax for preventive migraine prophylaxis for my Sturge-Weber patients, because it has some effects on your intraocular pressure as well. It's kind of a milder form of Diamox. We mentioned Diamox in the past. So if I need to start a preventive headache medication for my Sturge-Weber, it's actually an anti-seizure medication as well. So it's a triple whammy. So it's a great medication, can help your eyeball, can help your headaches and your seizures as well. There's multiple other possibilities if that doesn't work for you. What's sometimes forgotten, and I think it's very important, is to evaluate for any kind of developmental delays or cognitive impairments. And this is something, if we can find an area that's difficult or challenging for the child, and we can support that at school, we can optimize their learning and maybe decrease frustration and whatnot. So it's really, really important to get everybody evaluated and get them the support they need to be at the best possible outcome for the future. ADHD or attention deficit hyperactivity is very common. Autism is not that common. It's more common to have kind of dysregulation and hyperactivity, and then some specific learning issues with either reading or auditory comprehension or whatnot. So have your child evaluated so the school can support them the best they can. And we want to do this before 18 years of age. Recently, I've had many of my patients have grown up being adults, and if we don't get the diagnosis and kind of tweak down the deficiencies during childhood, it's more difficult to get help when you're adult. So that's why I recommend everybody to get treated. So how do we treat? So aspirin, I nowadays start aspirin on all my patients with Sturge-Weber. And what it does is I mentioned in the beginning that when the vascular structure is abnormal, the blood kind of tends to just kind of hang in there and sit. So we want to make that blood thinner and more flowy so it can circulate easier. So nowadays, most of my patients will put on aspirin. There was a thought of aspirin even lowering the amount of seizures. I think this is just associated with better blood flow and better oxygen and metabolic demand delivery to the underlying brain tissue. So kind of helping with that vicious cycle I mentioned earlier. I already mentioned some preventive medications for the migraine. And I mentioned Topamax or topiramate being one of my personal favorites for Sturge-Weber patients. I wanted to put a little plug in there for epilepsy management as well. We've done several surgeries for our Sturge-Weber patients. So if it's safe to resect that brain tissue that's irritated and causing trouble, we can then help the healthy parts of the brain function in a normal, healthy level and minimize the long-term effect of seizures in development. So we'll evaluate everybody with Sturge-Weber if they are surgical candidate. But if they're not, for example, bilateral Sturge-Weber patients are not candidates for focal resection. There's other surgical things that we can do, vagal nerve stimulator and whatnot. And earlier, the better. And then the last thing I want to mention, and I'm sorry I'm late, I talked longer than I was supposed to, but when to image. So if there's a vascular change on a big area on the face, so high risk area, we'll do an MRI. But repeating yearly MRI is not necessary, only if there's a new symptom concerning for brain involvement. So seizures, we'll do imaging. You know, if there's a worsening of headaches, we'll do imaging. Or developmental changes, we can do imaging, but we don't recommend doing serial imaging as well. And I mentioned trying to limit the CTs in an ER visit because the radiation long-term is not healthy. I think that's just, can I talk? Is it okay if I talk a little longer? Just one more thing. Sorry. I wanted to just show this. So if your child has had imaging done, 10 years ago, and the extension of the disease was said to be a certain way, nowadays we have new imaging modalities and we can see smaller changes better. So head CT here, calcification, the involvement of the brain tissue looked quite small, and then higher resolution MRI, the area looked bigger, and different newer imaging sequences, we can actually find brain involvement in other areas too. So we thought that the brain involvement is only on the frontal lobe, but there's now new imaging sequences, and we can find the changes on other areas. So kind of make sure that how you have the latest and newest imaging modalities, especially if we talk about surgery. And I think I'm going to stop there and then open it for questions. I apologize. I tend to talk.
Nope. It was a great lecture, so please don't apologize at all. I know it's a little bit late and it is a Friday evening, but are there a couple of burning questions that people wanted to ask Dr. Steenari? Dr. Steenari, do you mind closing your slides and we could see everyone if that's...
Absolutely.
Thank you so much. And again, thank you for on a Friday evening. Again, I know it's late for everyone.
May I ask a question? So we are 6 years post-op left functional hemispherectomy. And we are seeing an excessive sensitivity to noise now. And it's also she's also showing a little bit of behavioral issues. So we were wondering if that's something you've heard of with other children having the surgery, or is it something we should be reaching out to her neurologist for?
I would probably reach out to neurologists. There's multiple possibilities, and I don't want to go through all the possibilities. Let me give you a few options. Sometimes after hemispherectomy, we actually see increased intracranial pressure because the blood products kind of cause changings how the cerebrospinal fluid is flowing and going around. So, that's something that I would look into myself if I saw your daughter in clinic after surgery. Sometimes if the seizures are now controlled, there are side effects on the medications on the same doses that you've been before surgery. I think it has to do with the irritability not being there anymore, and now the medication that were suppressing the seizures in the past, the same level is not needed. So now we're seeing more side effects. Just few quick thoughts that come into mind, but absolutely, yeah, talk with your neurologist.
Right, because we were also concerned because we had a meeting at the school today because she had hit a child after some things were said. And of course, it's always mom's having a baby this week. It's got to be that she's out acting out for that. But when talking with one of the teachers who was with her through it, who knows her for the last 4 years, she said she was blanking out, like she just wasn't there. So that's also a concern. So we reached out, but of course it's Friday. We probably won't hear back till Monday or Tuesday, but we're just concerned because we haven't seen this before. And again, I don't want to say it's because mom is having a baby and then push everything else to the side, because it could be something.
Yeah.
Especially seeing the noise thing is just happened over the last 6 weeks.
Yeah. And it can be headaches too.
Right,
sometimes kids sometimes kids can't tell you, but they just feel off and then they act out.
I had that as my other, do you think it's headaches?
Yeah.
Okay, thank you.
Of course.
Is there any one final question?
Hi, I'm sorry, I'm off camera, but I have a question. My daughter is 2.5 years old. She has bilateral involvement, status epileptic. At 5 months is when she had her first seizure, and in and out of the hospital, and was not controlled until, I want to say, until about 10, when she turned 10 months old. She was left on 6 high-dose medications, which, thankfully, due to her neurologist, we were able to, as of last month, bring down to 2 therapeutic doses. Unfortunately, during that 5-month period, she had profound brain atrophy from her first scan to her final scan. She has some calcification on both sides, and we don't know where her vision is, if she can see, what she can see. She's going through a lot of therapies, but I just wanted to understand, there's so much controversial research out there in terms of brain atrophy and reversal of brain atrophy. I just wanted to see what your thoughts are. Is there something that you recommend? Stem cell therapy, just different therapies, different, gene therapy. I don't know what is out there or what is coming to help with, brain atrophy.
I'm also hoping for that kind of a magic treatment. Gene therapies are coming up, but unfortunately we don't have that yet. There's also some immunomodulation that has been used in Sturge-Weber, and it hasn't been very successful yet, but I know, it's under work. So I'm hoping that will come out. Now, meanwhile, what we can only do is symptomatic management. So we know that we can protect that brain tissue that's very, very not doing well already by limiting the number of seizures and then helping the flow of the blood that's in those abnormal vessels. So the aspirin and then the anti-epileptic medications, and then sleeping and reducing stress, and when you get sick, managing the fever and all that. But yeah, I haven't seen anything good yet with stem cell therapies or I know hyperbaric oxygen therapies and all that kind of always comes out, and none of that has been shown to be beneficial yet and can be actually dangerous. So seizure management and aspirin.
Okay. One other personal question is that, she, as of last month, she has these, ever since the last wean was Epidiolex, and it was a little over a month ago. And I've noticed like she's startled like several times a day, whether it's loud noises or certain touches. And we just recently, last week, took her in for an overnight EEG. She had a few startles, but it showed no seizure activity. But those startles happen several times a day. Do you have any thoughts on what those could be?
I have many thoughts on so that's great that she had an EEG. Sometimes we have what we call subcortical myoclonus or just increased startle from especially on the kids who have abnormal brain functions. Epidiolex might have treated them even though they were not seizures. So now coming off, you might see them more. There's also interaction with Epidiolex and a few other medications like Onfi or clobazam, so that might have lowered those medication levels as well. And we can see more what we call movement disorders with lower medication levels. So multiple reasons, but I'm glad to hear that she already had an EEG done at least. So that gives you a little more time to figure out what it is.
Okay, perfect. But you don't recommend, because it's not seizure activity, I shouldn't, go back up on any of the medications or anything.
If it causes distress and issues for the child, sometimes we'll do, because we also treat movement disorders with anti-seizure medications.
Okay.
So just have a chat with the neurologist who knows your child really well and kind of see if it would be beneficial.
Okay, perfect. Thank you.
So guys, we're at the top of the hour, the 6:30 hour, and I know Kristen is free. We all have our things to do, but I wanted to just say thank you, Kristen and the team there at UC Irvine. You guys are always amazing, and we had a wonderful talk tonight. Please email me if you guys have questions or concerns. We can try to get them answered wherever we need to. I do want to let you know that there is a patient chat this week on Wednesday, adult patient chat with Louis Sandoval, our psychologist. Next Saturday, we are going to have a a neurology roundtable where you can ask neurologists anything you'd like. There's an adult neurologist and a pediatric neurologist that will be there. But if nothing else, thank you so much. And thanks for staying late and doing what we do best. And we appreciate all of you.
Thank you, everybody. Have a good weekend. Thank you so much for joining us.
Thank you.
Thank you. Thank you.